Hi everyone, thank you for watching today's talk on educating everyone on Dilapan-S, where we'll be hearing insights and tips on the best approaches to educating staff and families on induction of labour with Dilapan-S. Our speaker is Alice Singleton, who's an education midwife at Morecambe NHS Foundation Trust, who shares valuable tips from her experience as a neurodivergent educator, how to help people with different learning styles by getting creative with making Dilapan-S educational aids on a budget, and why she encourages people to step away from using the Bishop score as an assessment tool. So let's begin.
Good afternoon, everybody. It's so lovely to be here. My name is Alice Singleton, and as Lydia quite correctly said, I am I'm an education midwife based at Morecambe Hospitals University Trust up in Lancashire. And I also am going to pre-apologise. I have a really terrible cold. As you all know, working in healthcare, once somebody gets cold, everybody gets cold because we all work so closely together. So do bear with me today because I will be coughing and spluttering. But it's an absolute pleasure to be here. I'm really grateful that you've all joined to come and have a little listen. What I really want to hope that you'll gain from today is that you'll be able to take some really helpful insights. As somebody who regularly trains a lot of staff on Dilapan within my trust, I'm hoping that I can help shift some of those perspectives that everybody learns the same way as adult learners, because we know that's not true. And also how to get across to staff how we go about giving Dilapan, but also how to talk to women about Dilapan and about shifting perspectives. Because obviously Dilapan is such a new induction method, we're not quite as what's the word I'm trying to look for? We're not very good at talking about it at the moment because we don't have the experience. So it's about learning how to get that across to staff. So learning objectives for this webinar session are going to be, sorry, Lydia, would you just flip that one? Thank you. So from my personal experience and my personal perspective, from being the key trainer within my trust, about how I would go about discussing the best approaches to learning about Dilapan with my staff. And you'd think that this would be a really straightforward answer about who we are going to educate Dilapan. You just think, oh, midwives and doctors, right? But actually, I want you to, and we'll talk about it later during this session, but I want you to really broaden your horizons when you're thinking about who we're training about Dilapan, because actually it's really helpful if we are training support workers and also our student midwives, because support workers can help us in the initial setup of the Dilapan, not actually giving it, but discussing it with women and setting up trays and things, helping on the antenatal ward. Student midwives, on the other hand, are great people to train in Dilapan on these early stages, because we know that they have the most time, basically. You know, they can sit and have long conversations with women and discuss these things and answer queries, for example. We're going to talk about stepping away from the idea of Bishop scoring and why that I think this is important. I know this has come up before in other webinars that Dilapan have done. And then we're going to talk about positive framing about Dilapan, how we get across that positive message, and don't take those external perspectives with us, because, you know, there aren't that many people that have had Dilapan as an induction of labour method. And it's trying to focus on the positives rather than, it's a very new thing and we're not very familiar with it. It's about trying to make sure that we're going forward with it in a positive light. And then the last thing that I'm going to be talking to you about is understanding by midwives and doctors. So I feel that this is one of the things I've found in my training of staff, is that if they don't have a good understanding, your midwives and doctors, of what it is you're trying to do, where you're trying to place the Dilapan, what the outcome is going to be, then I don't feel like they inform people as well. So what I mean by that is, for example, if the midwives don't understand why the cervixes are funneling, then they aren't going to realise what impact that will have on the women's induction of labour pathways. But equally, they'll carry on doing it because they won't realise what the anatomical kind of impact of what they've been doing is. So That's what I'm trying to get across. I know that all sounds very wordy, but it will make more sense as I get along. So if you could move on to the next slide, please, Lydia. Just a little bit of background about me. So my name is Alice Singleton. Like I said, I'm an education midwife at Morecambe Hospitals. I'm also a rotational midwife. I work on the wards and also on the delivery suite. I am dyslexic. I was diagnosed in 2017 when I went to university, and it was a little bit of a shock to find out I was dyslexic because I'd never had problems before, but actually it makes a lot of sense now. And now as an educator, I really, really try to take that forward with me and actually use it as a bit of a superpower. I know neurodivergence is a very it topic at the moment. It's becoming quite a big thing, but actually it's about having that awareness and knowledge that we don't all learn the same. Our brains don't all work the same, as well as I think we're very aware that women and families sometimes take information in different ways, so we have things like information booklets that are simplified or in different languages, and we're very, very keen to do those kind of things. But actually, what about those of us that struggle with auditory processing or struggle with big chunks of text, for example? I am also going to be my own hypocrite. I'm just put my hand up and say there is a lot of words on this PowerPoint in general, and that is just because I really struggle with online teaching. I really try and do interactive face-to-face teaching as much as I can because I find it works the best. It's the most effective method. I really love alternative, out-of-the-box thinking types of educating, and I find the best way of making learning accessible is just to be really approachable. So quite often I'm on shift with people and I'll go, do you want me to come and help you do Dial-Up for the first time, or do you want me to just stand back, and then if you need help I can come and help you or help you set your trolley up, or do you just want to have a discussion again about how you think you do it, and then we can sort of talk through it. So I work within University Hospitals Morecambe, like I say, and we are one of the largest geographical areas that a trust covers. So we are 3 hospital sites within our area. We have 2 obstetric units. We have 1 obstetric unit in Furness General, which is called South Lakes Birth Centre, but not to confuse you, it is an obstetric unit, even though it's called a birth centre. We then have Royal Lancaster Infirmary. We have another obstetric unit down there, and then in the middle we have Kendal, which is our midwifery-led centre. And I provide teaching across all 3 and training all 3 sites, and also the community staff. So it's a big area to cover. But I'll come back onto that in a minute. We've had Dilapan-S as an induction of labour option for all women undergoing induction of labour since August last year. Before that, we had it for several years, but we only used it for VBAC ladies, so vaginal birth after cesarean section inductions, and it was only done on a delivery suite in lithotomy by a doctor. And I'm going to come back to that in a bit because it's quite interesting why I'm saying that. So the trust I work for, like I say, we cover two counties, and also we have a lot of crossover. We get a lot of out of area ladies, and I'm saying that because it's difficult to know what antenatal information they're accessing, because it depends if the trust in their areas are also providing Dilapan-S, and so that's why I'm just planting that seed in your brains. So like I say, we have Kendal in the middle, which is your blue dot, and then at the bottom we've got our obstetric unit in Lancaster, which is where I predominantly work, and then the green is SLBC, which is South Lakes Birth Centre, which is based in Furness General Hospital. We obviously, because we are so close to the Yorkshire border as well, some of our ladies do come over from places like Skipton, and we have dual care cross trusts. Next slide, please, Lydia. So the initial rollout for Dilapan as an induction of labour agent for all women, as opposed to when we used to just use it for VBAC induction of labours, initially there was quite a bit of resistance, and that was just because we'd only been used to doctors doing it. A lot of the midwives just couldn't understand how we could go from doctors, obstetricians, inserting Dilapan in lithotomy on delivery suite, and now we're saying, oh, anybody can have it, we can do it on a ward, and we can do it this place, we can do it that place, and the midwives were just like, what? Why is this perspective shifted so much? And actually, I think that's why initially there was so many preconceptions about Dilapan, because of the history. Because when they thought of Dilapan, they thought, oh, that's only for high-risk women, and oh, it's really difficult to get in because doctors must do it, you know. So those kind of perceptions always used to jump to the forefront of people's brains when I was talking to it about it. There was also a slow uptake as the community midwives weren't particularly familiar with discussing it during the birth pregnancies. So the women would come into hospital, there'd be a counsel for induction of labour, and they'd be like, Dilapan, what's that? Like, I've not heard of that from my community midwife. So then they were favouring prostaglandins, for example, because they'd heard of that. They'd discussed that with the community midwives. So there was difficulty training all the staff on all 3 sites just due to shift patterns and geographical areas. And I initially concentrated the training, and so did Lydia helped as well. We concentrated on training inpatient staff as a priority, obviously, because they were the ones actually given the Dilapan. There was quite a resistance to change as midwives. We are sometimes a little bit like that. We don't really like change. A lot of change happens, but that, you know, change can be a good thing. As we get more technologies and things, and we learn more about anatomy and bodies and hormones, it can be really helpful. But it makes us feel very uncomfortable because we're so used to doing things in a particular way, aren't we? That our women come in, they have a CTG, they have their Broston and ProPress, and off they, you know, that's them for the next 4 hours. They'll come back, do their obs, listen to the baby's heart, etc., etc. Whereas with Dilapan, with it being non-hormonal, people were like, well, do I monitor them? Do I not monitor them? And then, you know, the Dilapan guideline was saying one thing, the fetal monitoring guideline was saying another thing, but now we've got them all fairly coherent. But again, that's always the thing when you get a new kind of technology, isn't it? Another thing that flagged up was that Bishop scoring just wasn't working with Dilapan. It wasn't representative of people's findings. As Hannah very kindly explained at the beginning, so Dilapan works by osmotic. It basically dehydrates the cervix, which causes the actual Dilapan itself to expand and to grow and to keep continual pressure on the cervix. And Dilapan doesn't have the same effect to the length and the effacement of the cervix as we were used to with prostaglandins and ProPress, for example. So therefore, the Bishop scoring system, it didn't connect the same. And again, I will talk about that in a bit more detail in a bit. But we were finding that, you know, midwives say, oh, the Bishop score's only 2, they can't be A or M full, but actually they could be 2 centimetres. You know, it's just this length that people weren't used to. So yeah, but I'll talk about that in a bit further on. Equipment learnings that helped. So those of you that are using Dilapan at the moment, you might be really familiar with these kind of things. But for example, the wedges were really helpful. We didn't have those initially, but the wedges that so the women sit on the top end of the wedge, and it causes their coccyx to swing out the way, just to give you a bit better visualization when you use a speculum. And we ended up investing in different types of speculum. So I'm just going to show you these now while I've got a moment. So this speculum here, was one that we invested in, which is a light speculum. I don't know if you can just about see that. So you put it into the patient, you lock it in place, and then you got a little light switch that turns on and off. We got to a point where we had to invest in these because we didn't have enough speculum lights, which was something we never even thought of initially when we were rolling out. But the way it works at Lancaster is we have an antenatal postnatal ward and a delivery suite. The antenatal postnatal ward is just a ward. It didn't have speculum lights on the ward, and so it was really difficult for the midwives to be able to visualise cervixes. So those were a really good investment that we made. We also, for those of you that get a lot of patients that are gram multips or ladies with poor elasticity of the vaginal walls, this was another good one that we came across. So it's a speculum that you put in that's normal, you lock it like so, and then you have a little insert that goes inside the cervix like that, and then it opens out. Can you just about see that? I always explain it's like a petal, so it like opens up and it holds out the vaginal walls outside of the way. Okay. All right. So, they were really helpful. Another thing that really helped us was understanding the sponge holding forceps. So initially, as a cost thing, the trust invested in plastic forceps. But as those of you know that use Dilapan, I can't think of the word, sorry. The grooves on the plastic bit of the Dilapan, they don't match up to the plastic forceps. And so what happens is this. Sorry, I've just broken my forceps. That was rubbish. So you go in and then they start moving because they just don't have the same grip. Whereas with the metal forceps, which we later invested in, obviously there's more cost with the metal forceps because you've got to autoclave them, you've got to order them. But the Dilapan do not move at all. So it means when you're in the patient with a cervix, it doesn't matter which method you've used, whether you've used manual method or whether you've used speculum, it means that Dilapan is basically going to go where you want it to go rather than it going off wherever it wants to go. But yeah, the initial rollout as well, we kept having funneling cervixes. For those of you familiar with Dilapan, you might have come across this. It's basically where the external os of the cervix opens and the internal os remains shut. It's generally because the Dilapan slits have not gone deep enough. They've not gone through the internal os. But again, you don't always know that because we don't know how long people's cervical length is, for example. We don't routinely scan people's cervical length, but it was about getting across to midwives that actually not done anything wrong, but it's understanding why this has happened so that it doesn't happen again, basically, or that we can negate the risk of it happening again. Okay. So next slide, please. So initially there was a slow uptake on our Dilapan, and I'll just go through this data because I probably really confused you all with this, but it's just the way that I was working it out. So the figures at the top, the two top, that was per site, so we split it between Lancaster and Furness General Hospital because we don't do inductions at Kendal because it's a midwife-led centre. We only do it within the obstetric units, and we don't currently offer outpatient induction at the moment. Just because of our geographical area, it was deemed that it just wasn't safe at the time. Whereas, you know, with Dilapan, who knows, we might be able to at some point in the future. So the top two figures, they show the uptake of Dilapan compared to prostaglandins and cervical rightening balloons, which we have at Barrow. We use the, I can't think what they're called, the one with two balloons, not the Foley's balloon, the other one, Cook's balloon. So they use Cook's balloon, but Lancaster don't tend to use that the same. So as you can see, the uptake was a little bit slower at Furness because they were still using their cervical rightening balloons quite a lot. And then as you see in the more recent figures down below, so December, January, February, I've combined the two sites together just for ease of understanding. So we're now up to about a quarter of our inductions over both sites are now Dilapan, which is fantastic. Absolutely brilliant. It's been a lot of hard work from a lot of staff to try and get those rates up. You know, really focusing on antenatal education and getting across, you know, the benefits of Dilapan to the women, and so they can make a really informed choice as well. So yeah, I just thought you might be interested in seeing that. So next slide, please. So my passion. So this is me. I'm an educator, I'm a midwife, but I also really, really passionate about giving everybody the same opportunity to understand, because I've been in that place and I know how difficult it is when you don't understand something and trying to get across something that you don't understand. it comes across to the women. They understand that you don't understand, and that just causes confusion. It can sometimes lead to a bit of distrust because, they think we're brilliant, don't they? Most of the time, they think, "Oh, I'll ask my midwife because she'll know that." And actually, if we aren't as adult learners, as healthcare workers, if we aren't able to access information in information ways that is evidence-based, but in ways that we understand as learners, then how are we supposed to take that information, digest it, and pass it on to women? But it's impossible, isn't it? So it's really important that as healthcare workers, that we have that evidence-based information so that women then get the evidence-based information and can make their own informed choices on their own care. And so my question to you basically is, if we as healthcare professionals sometimes have difficulties in understanding information, what about our women and families? Because we are constantly learning, updating, researching, aren't we? We're getting the latest research and then we get taught about it, and then something else comes out and then we get taught about a new technology. But if we're struggling to understand that, our women must be as well, because we are the same at the end of the day. We might have different levels of knowledge on certain aspects. Obviously, we are experts in obstetrics, but in terms of learning, we all learn differently. That's effectively what I'm trying to say. Next slide, please. And then again, I know that neurodivergence is a very it topic at the moment, but I found it very interesting just to have a quick look online. So NHS England Workforce Training and Education says that neurodivergence describes the minority group that diverges neurologically from the said norm of learning. And it's estimated that 1 in 7 people are affected by this, although with an increase in awareness and late diagnosis, this is likely to be higher. And it alters how somebody digests, learns and takes the information. So basically, if we aren't making the information accessible for our learners, which is you guys, so are the people delivering the care, how are they then going to accurately provide that information to women in ways that women understand? So next slide, please. And so I had a little bit of a deeper dive into it. An NHS England Workforce Disability Equality Standard 2023 data analysis report for the NHS Trust showed that nearly 1 in 4 members of our NHS workforce have lived experience of a disability or a long-term condition under which neurodivergence sits. Not necessarily that it is neurodivergence, however, it just shows the impact that, actually there's a lot of us, neurodivergence comes hand in hand, doesn't it, with that kind of wanting to be more hands-on, potentially less academic in writing. And I mean that by... sorry, I'm going on a waffle now. Let me just... sorry. What I mean by that is we look at things slightly differently. By looking at things differently, it can help other people to look at things differently and understand them, if that makes sense. Adapting our learning to our audience and their needs, which is essentially what we're trying to do when we're talking to women about induction, isn't it? We're trying to put it at a pace, at a level that they understand. Next slide, please. So why is it important to educate everyone on Dilapan? So I found that face-to-face is really important to do rather than online. As you can tell, I'm not particularly au fait with online teaching. I'm not a massive fan of it, and that's just because I can't talk to you, I can't interact with you the same. I can see a couple of faces, but really I can't see what the general picture, can't see if people understand what I'm talking about. Being really interactive, being really heavily model based. So I generally do my teaching in small groups or one-to-one. I take my box with me, which has Dilapan written on the side of it, because I'm well snazzy like that in a Sharpie. And I carry it, and it has all my models in it, has all my bits and bobs, and I always carry a box of out-of-date Dilapan sticks. And I know that sounds really strange, but it's just because I think a lot of people didn't realise when we first started using Dilapan that they're individually wrapped. So explaining to them that actually, you know, each Dilapan stick is in its own packet, and it comes by itself, so that you know if you need more than one, you know how many to get out, for example. But people just assumed that because we give 4 or 5 Dilapan sticks at a time, that there was common packs of 4 or 5. So that was an interesting conversation at first about them having a feel of it, you know, and actually seeing how hard they are, that they don't really move, how well connected the ends are. You know, you can't easily get that off. I always take a before and after. So obviously that's your before. And then I always carry a urine, well, it's not actually got urine in, just so that you don't panic, but with an after. So before it's been inserted, after, and I've literally just soaked this one in water, and it's just to feel the difference, to feel that it's squidgy, it's soft, you can move it around, and actually, because people were concerned at first that, you know, actually, is it really painful, is it really uncomfortable, you know, a bit like sometimes people explain that heaviness with cervical rounding balloons. Do they have that with it? And it's actually discussing that, no, they're quite firm to start with, but actually when they start to dilate, they're really squidgy, they're really soft, they're really comfortable for the women, and it means they can move around, it's normal. I usually let them, like I say, I just let them have a play, because they're like, oh, that's quite interesting, actually, to be able to see what it feels like, and tailor it to the people's jobs. So, for example, if I'm talking to community midwives, I'll show them the Dilapan sticks, talk to them about how to talk to women about Dilapan. So about the benefits of having a non-hormonal induction. And if, say, for example, I was talking to one of our healthcare assistants, I'd be talking more about how to set up the trolleys for Dilapan, because it is fiddly. You know, it's really difficult to do it by yourself. We're not octopuses, and actually having an extra pair of hands who sort of knows what they're doing, sort of knows what to hand you, is really helpful. So most of our healthcare workers now are au fait with how to set up the trolleys, just to assist the midwives, not obviously going to be performing Dilapan or anything like that, but it's just so that we've got those sterile fields, and it is a little bit more tricky to get Dilapan into place, and I hold my hands up, it is, but it's being set up and being organised is a massive saviour of making sure that you're efficient and smooth with putting it in. Next slide, please. So all healthcare professionals that are involved in care of pregnant women and families, I feel, need to know about Dilapan. So community midwives provide the knowledge to give the women the power to choose. So they are the ones that give the women the initial knowledge. So when they come into hospital and they're being counselled because something has changed and they need induction of labour, they've already got that knowledge and that power to choose because they've already heard about it. Antenatal clinic, triage, DAU midwives, they might get women directed straight for induction of labour from these areas because they've come in with the second episode of reduced fetal movements or something like that at term, and they've decided to induce them. So it's about giving those midwives in those areas that are sometimes a little bit away from the main part of the hospital. Sometimes they're based on site. Our triage, for example, is based on our delivery suite, but I know not all of them are. And it's just making sure that they have the power to discuss it with the women as well for informed choice. Student midwives, like I said before, they have the most time in the world to do these things. As midwives, you know, you can quite often have, 4 antenatal patients and a couple of postnatal patients on a mixed ward. And you don't always have that time to have that really in-depth conversation about Dilapan, because a part of you hopes that somebody else has had it. Part of you thinks, I'll have to do it in a condensed version. But actually, if you've got a student midwife that understands Dilapan, it's brilliant, because you can just say, right, do you want to go and have a really good discussion with them, make sure they understand about it, understand the benefits, and we'll go from there. And support workers again. I'm going to stop talking about support workers, but they are like so helpful because we aren't octopuses again. Yeah. Next slide, please. So let's talk about Bishop scoring. So I used to, it used to confuse me, Bishop scoring, when I was a student, and then I felt like I finally got it, and now we're like Dilapan, and I'm like, it doesn't work with Dilapan. So Bishop scoring, most of you should be familiar with this. Either you have used it or you currently use it. So it's quite old now, and basically it's about, we're scoring the cervix as to how favourable it is for ARM, basically, or for labour, if we're thinking about it in that sense. But actually, now what we're finding is it's not representative of the cervical findings as to whether they're actually favourable for ARM. Because, for example, as I was saying, Dilapan doesn't tend to have the same effect on the length of the cervix and the effacement of the cervix as our conventional prostaglandins. So they tend to score lower in those, which brings the overall score further down, which would then indicate that they possibly weren't ARMable when they actually are, because they're not going to get rid of the length, so that part of the score is not going to improve, if that makes sense. Next slide, please. So it's that awareness that Dilapan doesn't have that effect than conventional prostaglandins, and actually that Bishop scoring does not reflect as well with dilatation only changes. Moving away from, a lot of what I used to hear was after people had had Dilapan and they'd taken them out, it was like, oh, I just give them a prostin to get rid of the length of the cervix. And you're like, okay, that's kind of not the point, because we've gone from a non-hormonal induction to a hormonal induction now. Or it'll help shorten the labour if you give a prostin. Again, not really what we're going for here. Or it will reduce your time on syntocinon if you have prostin. And again, we know that's not true. It's all about the data, and unfortunately I don't have enough data at the moment to show you, because we have only been using it full time for 6 months. But there's no evidence that it shortens labour, it reduces the time of syntocinon, if they were to have multiple methods of induction, for example. But it's just because, and what I find when I talk to staff is they're just not used to it. They're not used to people having length to the cervix. Next slide, please. So a little example with this Bishop scoring. So just a little test one for you. So the example on the left, I've given her a Bishop score of 6 because it's really soft, really short length, posterior in the -2 station. But she's actually not ARMable because she has got no dilatation to her cervix, whereas the lady on the right hand side has dilatation to her cervix, but she's got a lot of length. She's still possible to do an ARM. Yes, it might be slightly more difficult, but actually, when you think about it, that's the length. It's the length is the only thing that's different between those two women. Okay, next slide, please. So positive framing when we're talking about Dilapan, and what I mean by this is that we're really drawing on those positives of the method in comparison. So we're saying, for example, it's not hormonal. There's only one contraindication, that it's an active genital tract infection. Flexible, it's comfortable, you're able to move around more. Women generally report that they slept better, so they're more prepared for labour, and they could have more than one round of Dilapan potentially. It's not something we currently offer in our trust, but it is something being spoken about. And I know other trusts have more than one round of Dilapan. From our data, so far, we've not had any instances of hyperstimulation or tachysystole, which is massive when you think about it in comparison to prostaglandins, because obviously that there was always that risk with prostaglandins. We've got to think about these babies that we're querying whether they are actually fit to labour. And what I mean by that is it's something that our fetal monitoring lead says all the time. She says, we need to check, are these babies fit to labour? And actually looking at their risk factors, for example, they're severely IUGR or severely fetal growth restricted, and Is it that they're potentially compromised or they have little reserves? We don't want them to be going through a long prostaglandin-led induction and put under stress to then go into labour, because they've already had all the reserves compromised, haven't they? Whereas obviously with Dilapan, with it being non-hormonal, gives rest for the woman, rest for the baby, if you think of it that way. Next slide, please. So, excuse me, having a good understanding, so everyone learns differently, as I've explained, patients, families and healthcare professionals. Visual understanding can be really useful for everyone struggling to combine anatomy and with understanding and processes. Personally, as I am a bit of a crafty fellow, I do enjoy, I find animation really helpful for trying to get this across. And I'll show you this in a second, because I've brought a little animation for you to look at today. Initially it's time consuming to make an animation. Like, I'll hold my hands up, not everyone's got time to do it. But actually, once you've produced it, I've probably played this video over 100 times now. During training people, and it just helps for it to click into place so that they understand what it is I'm verbally trying to get across, but also they can visualise the anatomy and the understanding of the process, and that Bishop scoring is subjective and it doesn't reflect Dilapan accurately. So I'm going to shut up for a minute and rest my voice, and Lydia is going to play a video that I've made. I also hate my voice on it, so please don't judge me.
Hi everyone, so I thought today we'd talk about Dilapan, seeing as it's such a new thing to us midwives. In the background, I've just done a time lapse of a Dilapan in some water over 2 hours, and I've just sped it up just so that you can see the process of actually how quickly they grow and what they look like. As you can see, it's not really an instant process, but they very quickly change consistency and colour. So let's have a look at how do we actually administer Dilapan. So there are 3 main methods. You can use a speculum, you can do it digitally using sponge holding forceps, or you can do it completely digitally and use your fingers to push up the Dilapan. So let's have a look at each of these methods in a little bit more depth. First of all, we're going to talk about using the speculum. You would sight the speculum as normal. You would then insert them in turn into the cervix until you've got 4 to 5 Dilapan into the cervix. At this point, you would then remove your speculum very carefully, ensuring not to trap the strings and accidentally pull the Dilapan out. Then going digitally and push the Dilapan up to make sure that they were through the internal os. Let's now consider digital administration of the Dilapan using the sponge holding forceps and inserting the Dilapan one by one as you previously have done with the speculum. And finally, let's look at how to administer Dilapan completely digitally. In all 3 methods, you're going to do essentially the same thing, making sure that you've just put enough lubricant on the end of the Dilapan to assist with the administration of them through the cervix. You're also going to ensure, once you've administered all 5, that they are definitely through the internal os by giving them a little push up digitally. Once they've been in for the designated amount of time, you can remove them by pulling the strings. A gentle assessment is to check that we are ARMable, and it's as simple as that. I hope that's helpful, and if you need anything or want to ask any further questions, please don't hesitate to get in touch with me. Thanks so much for watching.
So I know it's a bit silly. I know it's a little bit unconventional, but actually a lot of staff that have struggled to understand the process of Dilapan, it's really helped them. And it took me ages to make it, I'm not going to lie to you. I absolutely hate my voiceover on it, but things like the time lapse of the Dilapan stick expanding, people are like, oh my gosh, yeah, that makes so much sense now, rather than, the pictures that quite often come on the Dilapan training of them at different lengths of time. Actually physically seeing the Dilapan expanding is really, really beneficial, because you think, oh yeah, that's how it works, obviously. And understanding about, the pushing up to make sure it's through the internal and external os, which I'm going to go on to in a minute. But yeah, I hope you all enjoyed that. And again, I'm sorry, it's a bit silly, but I've had a lot of positive feedback from staff about it that's really helped just cement that teaching. Next slide, please.
Hi everyone.
So discussing it. Oh, You don't want to watch it again, I'm sure. So understanding cervical anatomy. So this was something that, we're all sort of familiar. There's an internal external os and that there's length to the cervix. But before I started using Dilapan, I don't think I really knew that, understood that. And actually it's a massive thing with Dilapan because cervical length varies in length from woman to woman. Then obviously it can be affected by things like LETS procedures or cervical biopsies and things like that. If the Dilapan doesn't pass through both the external and internal os of the cervix, then the cervix will funnel essentially. And it's about ensuring that first Dilapan stick, when it goes through, is through that internal os and making sure it's definitely through, because otherwise you are going to end up with one opening, your external os, and it dilated, and your internal os is going to remain shut, which is going to be an issue because you can't ARN if your internal os is shut. So again, it's about talking when you're talking about putting the Dilapan sticks in. The first one, you just put it in. It doesn't matter how far it goes in, so that you can guide the rest of your sticks in around it, so you're not occluding the external os. So I'm getting all muddled now. You've added them one by one, and then at the end you go back in like I demonstrated in the video, and you're pushing them all up to the cap so that you're making sure they're through the internal and the external os. Quite often just demonstrating with my fingers, and I know that's a bit bizarre, but I just think it really gets across that method that you've got to get it in and then you've got to push it up once you've got them all in place. Next slide, please. So yeah, models on a budget. Again, I apologise about this, but I've done quite a bit of nicking. So why make models? Why would we have models? Now, we didn't have any cervical models. We just didn't have any as an education team. It wasn't something we'd ever needed before. So I did a bit of pilfering and stole some models from other departments and things, but I also made my own. This has been one of the most helpful for a lot of people. So these are just Dilapan sticks I put in. I hope you can see this okay. So I put a little picture of the same one on the board. It's an egg box. That's what it is. It's an egg box, and I've just pierced holes into the top of the egg box. And basically what I use it for is people to practice. Sorry, I'm losing all my Dilapan sticks now. They can clip on the sponge holding forceps and they can try and insert into the cervix, and then you can just check doing and undoing the forceps and get used to doing it before they have to do it with a real patient. The other one I use is this one. It's the same. It's got an egg box at the bottom, but it's got an inflated balloon inside around the outside, so that you can practice using the speculum that holds open the vaginal walls. And then the third one, if any of your consultants do teaching on coils, they let me borrow one of their coil models, which could be really helpful because you can move the cervix out of the way. So yeah, just as a little bit of a tip. Next slide, please, Hannah. So yeah, it's great for engaging, making sure people understand, and dexterity and getting used to handling the equipment. Next slide. So the benefits of interactive teaching kind of come across really. So they facilitate collaboration, customised learning, enhance student engagement with the technologies and the training, facilitates multisensory learning, and it's flexible because I can just take it along with me and practice. We don't need a patient as such. Next slide, please. So I'm currently monitoring our Dilapan use of induction of labour methods across both sites, and I'm sure I'll get the results at some point and be able to share them with you. But monitoring our training uptake has been very interesting as well, and actually training particular groups of staff. So, for example, the community midwives, and then how I saw that affected our induction of labour rates. It was really interesting. So, trying to discuss and answer questions about Dilapan-S with the community midwives. I'd like to eventually monitor induction of labour in terms of only Dilapan versus ladies that have had Dilapan followed by another hormonal another hormonal method. So, for example, the panoprostin progress after the Dilapan. I'd like to continue monitoring the mode of delivery compared to the mode of induction of labour, but at the moment we've got too small an uptake of Dilapan to be able to compare it directly to other agents. And I'd like to look if funneling cervixes are linked to professionals themselves or technique of insertion. So whether it's because they're using speculum and actually they're pulling them out slightly when they're coming out with the speculum, or whether it's just understanding and its technique. So it'd just be interesting to see that. Next slide, please. And that is me pretty much done. So I'm just going to quick recap. So teaching people about Dilapan best done interactively. Education on Dilapan isn't just for midwives and doctors who are performing it. Stepping away from the idea of bishop scoring would be really helpful, because I feel like it would just make us have a better anatomical understanding of the cervix. It's outdated and isn't reflective of the effects that Dilapan have on the cervix. Positive framing helps to iron out negative preconnotations or bias from counsellors of the induction and labour agents, and a good understanding of the process of Dilapan can help counsel women, making sure that they have a really good understanding before they consent to any procedures. And that is me. So thank you very much for listening.
Thank you for watching. We hope you enjoyed this video, and if you would like to learn more about Dilapan-S and how it can help in your hospital, please visit our website, which is linked in the description.